Good evening. Welcome to the NYSGE 2020 lecture series, and welcome to tonight's program. We have a couple of members logged on, but we'll wait a few minutes for more attendees to show up, and we'll begin. Okay, my name is Julie Yang, and I'm at Montefiore Medical Center, as well as our speaker tonight. Welcome again to everyone joining us at the NYSGE 2020 lecture series. Tonight, this session will be recorded and posted to our website within 48 hours. So if you miss anything, you're more than welcome to go back and use it as a reference. Before we start, just some housekeeping rules. Just a reminder, everyone's microphone and webcam is deactivated. But if you'd like to ask questions to our speaker, there is a section in the control panels where you can do so, and we will address as many questions as we can at the end of the presentation. Just a few reminders, visit our website at nysge.org and follow us on social media. And if you have any questions, especially if there are future topics that you'd like us to discuss, email us at the email there, and we will like to address it. And now to our evening feature. Tonight, I have the pleasure to introduce Larry Brandt, who is the professor of medicine and surgery at the Albert Einstein College of Medicine, Montefiore Medical Center. And tonight he will be talking about what is that red spot.
I guess I have it now, Julie?
Yes, all yours.
Okay. Hi, everybody. Welcome. I'm glad to be able to do this. And everybody, I hope, is in a safe place and is doing well and thriving. These are very difficult times. And I guess what we're doing now is going to be the type of presentation that maybe we get more and more of, and we have less of the personal stuff that I really love so much. Well, regardless, we have all been in the GI tract and spend a lot of the time of our day in the GI tract. And many times we're in the stomach or the colon and we see something and we call it something, but really it's a red spot. And I wanted to talk about what is that red spot? What are we really talking about? One of the things that I've tried to stress over the last, well, more than 40 years is that when you look at a red spot, you should try and call it by the name it deserves. And I hear all the time people talking about AVMs, AV malformations. Well, in fact, an AVM, if you will, is a congenital lesion. You do not develop them. They are only present from birth on. They may cause a problem, they may not, but it is a congenital lesion. The term vascular ectasia and angioectasia refer to the same lesion. I tried to change the way we refer to these lesions only because basically I'm a linguistic snob, and I don't like the fact that ectasia is a Greek word and vascular is a Latin word. So I got the equivalent of vessel in Greek, which is angion, and I only refer to these as angioectasia. That's different from the term angiodysplasia, in which, although it's a purely Greek word, it refers to a vessel that is badly fashioned. It developed in a disorderly kind of a way. We'll come back to that in a moment. But angiodysplasia, if you don't know the nature of the lesion you're looking at, angiodysplasia is a pretty good term to use. It is not a telangiectasia, which are very small vascular lesions. As the name tells you, they develop from the end of a vessel. And we only see these in a disease like hereditary hemorrhagic telangiectasia. And then we have an angioma, which basically is a tumor of the blood vessel, a benign tumor of the blood vessel. And I have seen papers written in which in one sentence, every one of these terms was used. So learn the right terms and try to be consistent in the way you use them. How do we classify these lesions? Well, as I said, a vascular lesion may be congenital or it may be acquired. The congenital lesion is the AVM. The others are non-AVMs. These can be familial, such as Osler-Weber-Rondeau disease or hereditary hemorrhagic telangiectasia. They can be syndromic, like the Klippel-Trenaunay syndrome. They can be systemic and accompany chronic kidney disease and portal hypertension. They can develop as a consequence of aging, as the angioectasia does. They can be neoplastic. And then there are other vascular lesions, lesions of the blood vessels that I'm not going to be talking about today. And I've shown you two examples of these. Another way of classifying these is by the type of vessel and where they're located and how many there are. So you can have a vascular lesion that affects a large vessel, or you can have a vascular lesion that affects a medium or small vessel. They can be involving the hollow viscera or the solid viscera, such as the liver. And within a hollow viscera, they can be superficial, they can be deep, they can be transmural, they can be single or few, or can be many, and they can be grouped and they can be diffuse. So you can imagine how if you have a single lesion versus a diffuse process of the same lesion, how the therapy might be different. Here's an example of all of the lesions, what vessels they involve, and where they tend to be located. So the angioectasia is composed of very small arteries, veins, and capillaries. They can be single, or there can be many. These almost always occur in the proximal colon, and they always start in the submucosa and then extend as they develop to the mucosa. Hereditary hemorrhagic telangiectasia are venocapillary lesions. They're usually small. They can occur in both hollow viscera and solid viscera, and they can be very diffuse and involve different depths. Each lesion may involve a different depth of the hollow visceral wall. The AVM tend to be medium vessels or large vessels. They tend to be solitary. They too can involve solid organs or hollow organs and occur with varying depths. The hemangioma, same thing. They involve varied types of vessels. And then we have GAVE and portal hypertensive gastropathy. GAVE is a capillary lesion. It involves the antrum of the stomach and is confined to the mucosa. Portal hypertensive gastropathy is a venular capillary lesion that involves the fundus of the stomach or the body of the stomach and can involve mucosa and submucosa. Today, we tend to diagnose vascular lesions by endoscopy. Endoscopy meaning upper or lower tract endoscopic examinations. But historically, we used angiography to do that. And this plays a secondary role today. The CTA is really not a good test for a vascular lesion, and we use that mainly for active bleeding. The radionuclide scan, which is more sensitive in bleeding than is the CTA, can be used to localize the site and the activity of the bleeding, but not the nature of the bleeding lesion. We no longer do barium studies today. Sometimes they're used for AVMs, but in general, they're not really used. And I'm going to show you some special studies today that we did decades ago involving stereomicroscopy and vascular injection using a microfill preparation. That's only a research tool today. So let's start with the angioectasia. The angioectasia is the most common colon vascular lesion. It is a consequence of aging. You rarely see these in patients under the age of 50 unless they have aortic stenosis or they have an LVAD. These lesions present with recurrent bleeding, and the bleeding can vary from occult, obscure, to melena, to bright red blood per rectum. They are almost always located in the cecum and in the ascending colon. Not the distal transverse colon, not the sigmoid, not the rectum. If you see a red spot in the lateral sites, it is not an angioectasia. And I've studied many of those red spots with these research studies I'll show you, and none of them have ever been angioectasia. And then the therapy for the angioectasia varies on the lesion, how many you have, how old the patient is, comorbid illnesses, and it varies from just giving iron and letting them bleed to endoscopically ablating them, to microembolizing them, treating them with experimental anti-angiogenesis agents such as thalidomide or bevacizumab, and on occasion, even operating on them. These form because of obstruction by the muscles of the submucosal veins in the right side of the colon. And it probably occurs on the right side of the colon because that's where the intramural tension is the greatest, because the intramural tension is determined by the law of Laplace, and it says tension is directly proportional to the pressure of the lumen and the radius of the organ. So as you increase the radius of the organ, and the right side is greater than the left side, the intramural tension increases. And that can cause an obstruction of the submucosal veins. That causes a dilation of the submucosal veins. That causes a dilatation of the mucosal venules. That increased flow and increased pressure destroys or renders incompetent the prearteriolar sphincter. and then you wind up with a arteriovenous shunting of blood. Let me make this clearer for you. Here we have on the left side of the screen, here's the colonic musculature. The veins are draining through the colonic musculature. Now, this vein gets impinged upon by the muscle. The vein draining into that, the submucosal vein, starts to dilate and becomes redundant and tortuous. That pressure and that dilatation extends upwards towards the mucosa. You get dilatation of the mucosal rings here, mucosal vessels, the veins. As this goes on, this dilatation and tortuosity becomes more prominent. This is the capillary ring surrounding each of the colonic glands. And as we go on, the ring dilates, the prearteriolar sphincter gets destroyed, and now there's nothing holding up the flow of arterial blood into the colon, into the arteriole surrounding the gland, and you have an arteriolar venular shunt. So this angioectasia can form in the way that I told you, and this is associated with an increased expression of VEGF, and it's conceivable that hypoxia can also upregulate the VEGF-1 receptor, and that you may get a little bit more hypoxic as you get older, and certainly as you develop cardiac disease. Well, we're seeing a lot of these angioectasias and bleeding in patients with LVADs, but you also see this in aortic stenosis. And the reason for that is both of these entities, the presence of an LVAD and the presence of aortic stenosis, are associated with high shear stress. When you get high shear stress, that actually changes the conformation of von Willebrand's factor, and it exposes the site between amino acids 842 and 843, and that is the site where Adams 13, or von Willebrand factor cleaving protein, acts. Therefore, you get cleavage of the multimeric von Willebrand's factor, and what you wind up with is a von Willebrand's factor that doesn't control bleeding as well. And therefore, if you have an angioectasia, you will bleed from it. So what are we looking at here? This is a specimen of colon that was gotten from a patient at surgery, and the arteries and veins were controlled, and the specimen was injected through the arterial system with microfill, which is a rubber kind of compound. And then that specimen was opened and sutured to a stretching frame and placed in a bath of glycerol, which exchanged the cell water in the cells, the intracellular volume, with glycerol, rendering the specimen transparent. And what you're looking at here, each of these almost hexagonal areas is the vascular system surrounding a solitary colonic crypt. This then is an injected specimen, and in the back you can see the normal vascularity. But this coral reef-like appearance is an angioectasia. And this is an angioectasia in a specimen that has been transilluminated now. And this is the coral reef. And what you're looking at in the bottom right corner here is a common pinhead. So you can imagine how small this angioectasia is and how beautifully detailed it is. This is a angioectasia, and in the background, you see this dilated, tortuous submucosal vein that I showed you earlier on as the first structure to be obstructed. So it became obstructed here, deep in the submucosa. That pressure was transmitted up through into the mucosa, and these dilated mucosal venules, capillaries, and ultimately arterioles is what causes the ectasia that you see. This is something you don't see very often. Here we have the background normal, the ectasia rising above it like a coral reef, and this is some of the material we injected, the microfill, that is coming out of the lesion and spilling through the hole in the lesion that was bleeding prior to surgery. And this is a section through the colon showing the muscle. This is the muscularis. Here's the supply going up through the muscle. And here is the dilated vein that is forming above the compressed vessel. This is what we're looking at, what we're used to looking at. Here is the ectasia. And here is the draining vein behind it. Or this is the draining vein. Not this, but this. Or maybe this. It's very difficult in most circumstances to pick out which of the veins is the draining vein. And you'd like to know that for treatment. We'll come back to that. Here's some other examples. In the bottom left one, you do see the draining vein very nicely. Here, we'd like to think these are draining vessels, but we certainly see the ectatic foci of these irregular vessels. This is a diverticulum, and in the base of the diverticulum is a angioectasia. Now, were this patient to come in bleeding, and were you to have done an angiogram or a CTA, you might have seen the blood spilling out of this diverticulum. And you would have said it's a diverticular bleed. But in fact, it wasn't. This was a bleeding ectasia in the base of a diverticulum. Well, how did we make the diagnosis by angiography? And if you think about it, this is actually very logical. How do you do an angiogram? Well, you catheterize an artery, you inject contrast, it goes through the arterial system, and it drains back through the venous system. So if you obstruct a vein, as I showed you, you can imagine that that vein would have difficulty emptying. And as time went on, and you became more advanced in the lesion, the mucosal part of that would start to fill. And there are many of those mucosal parts of the more superficial veins and venules that I showed you. And then you would destroy that prearteriolar sphincter, render it incompetent. And now, when you injected contrast through the arterial system, you'd fill your vein early because you wouldn't have the prearteriolar sphincter holding up the contrast. And sometimes you'd even see extravasation. So you can understand why an early sign of an angioectasia is a late emptying or late draining vein. By late, it means more than 7 seconds into the angiographic study. And here is an angiogram, and this is a late emptying vein. The emptying of this vein is delayed. And here we see a vascular tuft. Here we see an early filling vein. This is early in the angiogram. You don't see any of the fine vessels yet, but you do see the veins draining. And you see a couple of vascular tufts. So this early filling vein tells you that this is a late stage lesion. What does it look like histologically? Well, here are in the submucosa, here are the dilated venules, and what you see is black filling the venules is the microfill, and you can see that in a lot of places. So this is an early lesion. This is a little later lesion, and now you see the submucosa here, the mucosa here, and now we're starting to get some dilated veins, venules, forgive me, in the mucosa. And as we go on, you almost can't tell the difference between the submucosa here and the mucosa here, because now the vascular spaces have come up into the mucosa, and in fact, they occupy much of the submucosa and mucosa. And here we see that in the mucosa, there's only a thin layer of endothelium separating the lumen of this capillary venule from the lumen of the GI tract, which is right here. How easy is it to break this with a lump of stool or some hard particle that you've ingested that wasn't well digested, and then have blood coming out a little bit into the GI tract? Well, this is the angioectasia as we look at it, but a lot of things look like that. I mean, we think we know what we're looking at, but in fact, we're not. And therefore, that tells me that a lot of lesions can be confused with angioectasia at endoscopy. Some of these are vascular lesions, as I've shown here. Some of them are non-vascular lesions, such as trauma, suction artifacts, colitis, neoplastic lesions, and non-neoplastic lesions. Here, for example, is a red spot, but it's a suction artifact. I created this just for a previous version of this kind of talk. Another red spot, this is portal colopathy. Another red spot, boy, that looks like an ectasia, and it's ectatic vessels, but this was actually a patient with Crohn's disease. And when I biopsied this, and I used to do a lot of biopsying of vascular lesions, I got granulomas here. This is Crohn's disease. And this is radiation colitis. So there are many factors that can mask your ability to see the ectasias. If you don't get to the ectasia, you're not going to see it. If the patient has a poor preparation, either by stool or mucus, you're not going to see it. And dehydration, hypotension, either by the prep that you gave the patient or by medication that you give the patient during the endoscopy, or anemia. Dehydration, hypotension, and anemia make it difficult to find ectasias. And the reason for that is that they empty out of blood. So when do we do most of our colonoscopy in patients who are bleeding? We do it as close to the bleeding episode as we can. Well, I would submit that that's not the right time to do it, unless the patient's actively bleeding and you have to be therapeutic. The right time to do it is really when the patient has stopped bleeding and when you've transfused the patient to a hemoglobin of about 10, because then the vascular system is full and these small lesions are easy to see. Now, that's my opinion, my studied opinion. I have never studied that in other than maybe a few cases, because it involves studying the patient, transfusing them, and then studying them again. How do we go on to treat these vascular lesions? Well, depending on the lesion, maybe genetic counseling in some of the syndromic lesions, maybe just replacement therapy. The patient is old and fragile. Maybe by correcting associated disease. Maybe in a medically or pharmacologically appropriate fashion. And the treatment ranges, and all of these are poorly studied. Hormones, mainly estrogens, vasopressin, DDAVP, somatostatin, TNF agents, thalidomide, interferon, bevacizumab, the list goes on. Endoscopically, usually we use APC, but in some cases, we've used injection therapy or banding or injection of microcoils by EUS, or even clip them. And sometimes we use angiographic therapy, super-selective embolization of these lesions, and sometimes we need to resort to surgery to remove the lesion and the adjacent part of the organ containing it. If you're going to treat these lesions endoscopically, it makes sense to stop anything that may foster bleeding: aspirin, NSAIDs, anticoagulants, antiplatelet agents. I already told you my philosophy about when to scope the patient. And maybe then you should consider, in a patient whose hemoglobin is 8, transfusing them before endoscopy to 10, sedate them cautiously. And I base this only on my experience with meperidine, Demerol, which I'll show you some work with in a second. Minimally distend the colon, aspirate before you treat the patient to thicken the colon wall, prevent perforation, be prepared for complications, maybe have surgical backup. This was more true years ago. Today we do APC and don't call the surgeons, but for some of these vascular lesions, you might want to. And remember that sometimes less is more and more is too much. Some examples: one ectasia I treated with Hetoprobe, and 2 that I treated with APC. This one was interesting in that it was between 2 diverticula. Not that that presented a danger, but you oftentimes see this lesion, which is capable of bleeding, next to this lesion, which is capable of bleeding, because both lesions are common in the elderly. How do you treat an ectasia? Well, if it's small, you can just hit it with the APC. If it's large, then what I would suggest you do is surround it in a dot-like fashion to create a collar of edema around the lesion, choking off the vascular supply, at least partially, and then treat the center of the lesion. If it has a linear aspect to it and a more spider-like aspect, come along the linear lesion first, then do the periphery, and then do the center. One thing you should understand is that the different lesions and the different parts of the lesion are affected by different modes of therapy, which have different depths of penetration. For example, the argon plasma coagulation unit primarily is a superficial mucosa-only technique of delivering thermal injury, especially with a circumferential probe, which doesn't go as deep as the end-firing probe. Monopolar coagulation goes very deep. We don't use neodymium YAG anymore, so don't have to worry about that. And heater probe, in general, is a much deeper lesion than that with the APC. You have to ask yourself, just because you see a lesion, should you treat it? If you treat it, when should you treat it? When it bleeds or not? Before bleeding? And how should you treat it? You don't treat a lesion just because it's present. I already said sometimes less is more and more is too much, but sometimes going beyond too much to perfect is not necessarily perfect. When you come back and look at a lesion like this, how much of this lesion do you have to treat? Half of it? All of it? If you have 15 of these lesions in the colon, do you have to treat all 15? Which one should you treat? Just the larger ones? The answer to these questions is not known, although I will tell you that I had a lady once who had 9 of these lesions in her cecum. Her daughter was a nurse and had tested her mother's stool every day for blood for a year. After I treated her, she also continued to test her stool every day for another year. She never had another positive stool. And I only treated 6 or 7 of these 9 lesions. I couldn't get to 2 lesions, technically. I was lucky. The 2 I didn't get to weren't bleeding lesions. But you don't know how many to treat. I would just tell you not to treat everything. Just treat the larger ones as a rule. This is something that you should know about, but you're probably not going to see it because we don't use meperidine anymore. But meperidine actually can cause the colonic vasculature to get smaller in diameter and can cause angioectasias to disappear. If you reverse the meperidine with Narcan, naloxone, you can enhance normal vessels and you can cause the new appearance of angioectasias, and you can cause pre-existing angioectasias to increase in size and to increase in number. Here's an example of such a phenomenon. This is an example of what the mucosa would look like, and there's a hint of an ectasia on the left side of the picture. And this was after giving meperidine. With the administration of Narcan and a wait of 2 minutes, it looked like this. and with the passage of time, look like that. So this was about, oh, maybe 3 or 4 minutes later. And you can see that it got bigger and it even started to bleed. This does not work with not meperidine. I just block what we use now. Somebody come up with it. Rather than meperidine, the drug that we sedate people with. I've been working from home so long, I'm starting to lose my pharmacology here. But it does not reverse the phenomenon of that agent. So what endoscopic technique is best for treating vascular lesions? And the answer is, we don't really know. And therefore, you should really do what you feel most comfortable with. Okay, that's a very important point. And one of my fellows just wrote me and said the name of the drug I couldn't remember was propofol. So thank you, Vipul. So when we treat a lesion, sometimes we're successful, sometimes we're not. We probably get a 75% success rate. But some of the factors associated with rebleeding of these lesions are if they're located in the stomach, if they're associated with systemic disease, chief among which is renal failure and portal hypertension and coagulopathy, if they're on medications that make them bleed, such as NSAIDs or aspirin, anticoagulants, or if you treated them insufficiently or missed some of the lesions. Okay, I'm going to move on now. I hope you all know what disease this patient has. This is hereditary hemorrhagic telangiectasia, and you can see the telangiectasias on the fingertips, vermilion border of the lip and tongue. And this is an autosomal dominant disease. It presents in childhood with recurrent epistaxis. It is unusual to bleed before the 4th decade of life. And when you see patients who are adults who bleed with it, usually they have melena, more so than they vomit blood, more so than they have bright red blood per rectum. So if you see a patient who has HHT and presents with rectal bleeding, chances are they have something else other than the telangiectatic lesion you think they may have, causing the bleeding. This is the vasculopathy that is primarily capillary venular. They have an ectatic tortuous blood space with a delicate single layer of endothelium and a very fine connective tissue. They have no elastic lamina, and that's why when you damage them, they continue to bleed because the vessel can't contract. The treatment for them, I've shown you here, maybe iron, maybe transfusion, maybe ablate them endoscopically, maybe operate on the patient. We usually don't do that. And sometimes we can even give them epsilon aminocaproic acid or bevacizumab. There are not many studies on that because that's very rare. There are 2 mutations that cause this disease, the type 1 disease and the type 2 disease. This is the ENG gene, endoglin, and the ALK1 gene. Both of these, or either one of these, I should say, can give a vascular dysplasia, more venous than arterial, and it makes a difference which one of these you have because there are different organs that are involved in the different types. Hemangioma. Hemangioma are usually present at birth. They're usually solitary. They can be multiple. They can be small or large. Focal or diffuse. They do not have a capsule. And they come in 3 different types: capillary, cavernous, or mixed. The bleeding here is usually slow, except if you have a cavernous hemangioma of the rectum. We diagnose these by endoscopy and angiography, and these are treated surgically or angiographically, more so than endoscopically. Here's an example of a plain film of the abdomen in a child, and what you see is multiple areas of radiodensity, and this is calcification within the vascular bed of the hemangioma, cavernous hemangioma. This is one of the few lesions that calcifies like this. And this is a barium enema showing deviation of the barium column by a calcified lesion, which is a cavernous hemangioma. The old AVM, congenital lesion, it's usually single, they're usually large, it may be syndromic, or have systemic sequelae. What's a systemic sequelae? Well, because of the connections between arteries and veins, they can have effects on blood pressure, they can calcify, platelets can precipitate in these areas, just as they do in some cavernous hemangiomas, and form a consumptive coagulopathy. They're diagnosed by angiography, more so than by endoscopy. They're often diagnosed at surgery, and the treatments are angiographic or surgical, much more so than they are endoscopic, because these AVMs tend to be transmural. Here's an example of one such lesion in the small bowel, and here's an angiogram of one lesion, also in the small bowel. I'd like to conclude with a differentiation of GAVE, the so-called watermelon stomach, and portal hypertensive gastropathy. This has watermelon-like stripes on the surface, although it can present as a punctate variety. And this has a snakeskin-like appearance, although it too can have puncta of hemorrhage. Portal hypertensive gastropathy is also is associated with portal hypertension, as the name connotes. GAVE is associated with portal hypertension only in about 30 to 40% of cases. Now that's important. That 30 to 40% is important because you don't get the same therapeutic effects in a patient with GAVE who has portal hypertension. You don't get as good an effect. You have to treat the portal hypertension. GAVE is more commonly associated with autoimmune disease, connective tissue disease, atrophic gastritis, and chronic kidney disease than it is with portal hypertension. GAVE tends to be a female disease. Portal hypertensive gastropathy tends to be more of a male disease because cirrhosis is more of a male disease. The GAVE tends to occur in elderly patients. You can get cirrhosis at any age. The location of GAVE, as the name states, is in the antrum. Portal hypertensive gastropathy is in the fundus. The endoscopic appearance I've already spoken about. The histology is a little different because GAVE has dilated capillaries in the mucosa, focal thrombosis, fibrin thrombi, and fibromuscular hyperplasia in the lamina propria. Portal hypertensive gastropathy does not. It only has dilated submucosal and mucosal veins and ectatic capillaries. GAVE can be treated better by endoscopic therapy than portal hypertensive gastropathy, which is treatment of the liver disease. And I think with that, I will say thank you. It's been nice talking to you. And I'm going to turn the program back over to Julie. Julie?
Hi, thank you, Dr. Brandt. That was a wonderful talk. Very thorough in what that red spot that you're looking at. There's a couple of questions, and if anyone has any questions, you can type it on the control bar and I will see them. Any questions that I don't get to, remember that you can email us and we will try to address all of those. So first question from our audience is, how do you differentiate between an angioectasia at the base of the diverticulum, as you had shown us, from a diverticular bleeding vessel?
The only way that you could do that is angiographically, because you would see the signs of the angioectasia. So if you saw the signs of the angioectasia and you could see the extravasation site and they matched, and it spilled into a diverticulum and then out, you could say that that was bleeding from an angioectasia. If you didn't have any of the signs of an angioectasia angiographically, then you would just see vascular extravasation into the diverticulum and then out again. And remember that you need to see that, the extravasation in the diverticulum and then spilling out of the diverticulum, if you want to say a patient has a diverticular bleed. But you can't say that if you can't say that there's an ectasia there if you don't see the angiographic findings of an ectasia. And I will tell you that that's probably very rare. You're either going to have one or the other, unless the patient has a lot of diverticula and then the blood is spilling in and spilling out as it just continues to flow.
Okay, great. And the next question from our audience is, the development of angioectasias, is the mechanism the same regardless of where in the GI tract lumen that you identify them? So whether it be in the stomach or in the small bowel?
Well, remember I said that angioectasia only occurs in the proximal colon. You do not get a red spot. It's an angioectasia that occurs anywhere else in the GI tract. So let's assume that you say, what is he talking about? I see this all the time. What I would tell you is that I have been sent over the years dozens of histologic specimens from surgical removal of lesions that people said were angioectasias. None of them were angioectasias. They did not have the dilated submucosal vascular spaces, the dilated mucosal vascular spaces. They did not have the early submucosal vein. If you want to prove that a lesion is an angioectasia, you're going to have to do some of those special studies. You're probably not set up to do that. But we've studied lesions in other places, and we've never seen them. So when I do cases with my fellows, and they say there's an angioectasia in the sigmoid, and it looks like an angioectasia, I tell them it isn't because I've never seen it. But in order for me to prove that, I would have to do a resection of that part of the colon, inject the vessels, clear the colon, and look at the lesion under a stereo microscope. Nobody's going to do that anymore. So can I tell you that no one has ever seen an angioectasia in another part of the GI tract? No, I can't say that. But I will tell you that of all the studies that have been done, the studies of the type I'm describing, none has ever shown an angioectasia in another part of the tract. Now, you can get vascular lesions in the small bowel that are associated with angioectasia in the cecum. Are they angioectasias? I don't know. They've never been studied and proven to be so.
Thank you. The next question, to follow along with the red lesions that we would see, particularly in the small bowel, for those of us who read capsule endoscopies, what would you call those lesions that you would see that look like angioectasias?
I'd call them angiodysplasia or vascular lesion.
And
That's why I like the term. You see, I know that they're not telangiectasias, and I know that they're not angiomas. So after that, and I know they're not AVMs, because AVMs look different than the lesion angioectasia. So to me, angioectasia means something specific. So in the small bowel, I personally would call them angiodysplasias, because I really don't know what they are because I haven't studied them.
thank you. The next question would be a clinical scenario that we see quite commonly in the patients who present with recurrent overt bleeding and associated anemia. They come in a couple of times for melena. You've done a bunch of endoscopies on them, treated them with APC, and because of their underlying comorbidities or diseases that they have, they keep coming back with the same problem. What would you recommend in those situations, and also where in your algorithm would you consider medical therapy such as octreotide?
Okay. Well, that is, as you said, a very common scenario. And it's a problematic scenario because there really are no good studies of any treatment for the vascular lesions of the type we're talking about. And the reason why I say that, and there are hundreds and hundreds of papers in the literature over the last 35 to 40 years on this. The reason I say that is that if you read these papers, they refer to the lesions by different names, or they combine lesions but don't process the analysis for each of the different lesions. So you'll have someone that there'll be a series of, let's say, 20 patients, and 7 will have HHT, and 3 will have angiomas, and the remainder will have ectasias. And then they will summarize the result and say 70% of the patients did well with treatment with APC. But they don't divide them up. So the purity of the lesion you're talking about really has not been studied. I can tell you that for the most part, this is probably not going to be studied any longer because most people have, at least endoscopically speaking, a point and shoot approach. We don't study them, we just treat them. And yes, they come back time and again. So now you have a patient who's been treated multiple times, and we've done evaluation of the small bowel either by capsule or by enteroscopy. And we've treated in the proximal duodenum, and we've treated in the stomach, and they keep on coming back, and there are more lesions each time. I think what I would do in that kind of a patient when they start to come in frequently is, one, I would transfuse them up to about 9 or 10. So now these tiny lesions, I think, should be maximally filled with blood and easier to see. And then I would treat them as best as I could treat them. And they've been treated several times before, but now we're doing the best job we can. I'm done treating them. I probably would not treat them again. So what would I do? Well, how often are they coming in and how old are they? And what diseases do they have? If they have portal hypertension, I'd probably treat the portal hypertension. But let's assume they don't. What are these old people who have CKD and bad heart disease? What would I do for that patient? Well, if I could, I would prefer to treat them with intravenous iron or give them erythropoietin or something like that, and transfuse them periodically and see how long I get out of those therapies. Because they may be bleeding at a rate that a unit of blood a month will hold them. In that case, that's the easiest thing to do. If they exceed that, now you have a problem. You could put an older woman on estrogen therapy. That does have a beneficial effect in some cases. Obviously, in a man, that's not as desirable a therapy. And for men who we treated with estrogens in the past for this problem, and they developed painful breasts, we actually radiated their breasts, low-dose radiation. Something sort of in past history. You probably wouldn't do that today, but you might not use the estrogens in the man for that reason. If you can't do that, you could try using a anti-TNF agent. You could try using thalidomide. Thalidomide has been studied in small numbers of patients and is effective for this. Small numbers of patients. You have to get thalidomide. You'd have to fill out a compassionate protocol. Difficult to do. Bevacizumab. Small number of patients. That's been studied mainly for hereditary hemorrhagic telangiectasia. If you used it in a patient with multiple angioectasias or angiodysplasias in the small bowel, you'd have to get the permission that this really has not been studied for this before, and you're doing something experimental. You have to remember that bevacizumab in this situation has been associated with intestinal perforation. So it's really a difficult situation, and you have to go through all of the possibilities and say, well, which one is right for this patient, and how much effort are you willing to go through for that particular patient to get it, because it might be quite difficult.
And one last question regarding therapy. If you do decide that you're going to treat an angioectasia or any vasculature that you think is a culprit bleeding or actively bleeding, do you recommend combination therapy? Do you go straight for APC? Do you judge it based on the lesion size? And if you are going to use APC, can you tell us how you decide when you'd like to use circumferential fire versus straight fire?
Yeah. I have never used combination therapy for an angioectasia. Most of the lesions most of the component of the lesion is veno arteriolar, capillary, and it's not going to contract so well with epinephrine. I have never clipped an angioectasia. I think if you clip the vein, it might make the lesion bleed more because you're increasing the resistance against a lesion. But you're right there, you're going to treat it. I just don't see it having an effective role. So I would just use APC or heater probe. In terms of using a circumferential probe or an end fire probe, in general, not with vascular lesions, I always use an end fire probe. Even if the lesion is large, I like using an end fire probe and painting the lesion back and forth. I know exactly where the beam is going. I have complete control over the beam, and I don't miss with it. So in my hands, that's my choice. I think it might be a little easier to use a circumferential probe when you have multiple lesions, although for the reasons I stated, I don't choose to do it. In terms of an angioectasia in the cecum, I think it's probably safer to use a circumferential probe than a end fire probe, because the depth of the argon beam is a little less with a circumferential. Regardless of which you use, before you fire it, step on the suction. Step on the suction. Push down the suction on your colonoscope so that you aspirate some air from the cecum or the ascending colon, because by doing so, you'll make the wall a little bit thicker and it'll be a little bit safer. And those are basically the elements that I consider when I'm doing it. And always test fire your probe away from the lesion. Don't go right for the lesion. Go away from the lesion and see whether or not the probe works and gives you the result that you want, so you know what you're going to get when you now attack the lesion. And remember that you're not in this business to be a cosmetologist. You don't have to do a perfect job. Just do a job that's good enough.
I think that's probably the best advice we've gotten today. And I thank you again, Dr. Brandt, for a wonderful, informative lecture. And I thank the audience for joining us tonight on an important topic that we see most all times when we do endoscopy. If there are any portions that anyone has missed, again, a reminder that this is recorded and you can refer to it on our website within about 48 hours. And any other burning questions that were not answered, please feel free to email us and we will get back to you with that. Thank you very much and see you next week for our next program.
Good night, everybody.